Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started. So I'm Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deere. Tim, how you doing today?
Patrick, I'm doing fantastic. How are you?
I'm doing great, thanks. You know, the Aspen Collaborative Summit in Nashville is just 1 month away. You know, there seems to be something for everyone at this course, whether it's the APP course, the fellows track, and of course, the collaboration between the pain and the spine community. What are you looking forward to most with this?
Well, I mean, you hit on all the major points. I think the Collaboration Summit, to me, is the most important thing in our specialty. I'm working now with a special group of people that's looking at trying to bring together progressive, like-minded people, whether it be interventional pain or spine, interventional radiology, orthopedics, neurosurgery, and those people are starting to come together. And we're going to create a collaboration, and we'll meet. A lot of us will meet there in Nashville. We'll have a discussion that day, and out of that will come, I think some important work on the next point, whether that be a subspecialty post-fellowship training program, a certification program, what that may look like to make sure patients are safe. So that's one. Two, the APP Summit. I think APP is becoming more and more critical to the specialty of interventional pain and to spine. And I think that, they're involved in patient selection for techniques. They're involved in follow-up. And in my case, my APP is involved intraoperatively. And then lastly, fellows. Many fellowship programs are fantastic, but some really are lacking on some of the newer minimally invasive skills. And we're going to work on that with these new young fellows and help them to see what they want to do once they leave fellowship. And I think exposing people to things. So to me, it's one of the most important meetings of the year. Our annual meeting, having several thousand people. This is much more intimate, a few hundred people. That's how it's designed. David Lee is leading the meeting, a good friend of yours, I know. And I think doing a fantastic job as well. So hope that many of you can make it to Nashville. If you try to come and they say that the section's full, let me or Patrick know, and we'll try to get you on board with us. So Patrick, I think that's a summary of it. That's our mid-year meeting this year. And a little plug for October of 25 in London will be our mid-year meeting next year, which is our biannual ISPN part of Aspen meeting. So this is something we plan to do every year, every alternating years in the U.S. and outside the U.S. and through our international component each other year. So that's a summary, Patrick.
Absolutely, Tim. So you mentioned that this is going to be a smaller, more intimate meeting, especially for our younger listeners out there. This is going to be even better to network, get those one-on-one times with, people like you, Tim, or industry and that kind of stuff, and really get your brand out there. So thanks for that, Tim. We want to thank our sponsors out there who have supported this Aspen podcast. Most of them are actually going to be at the summit: Mainstay Medical, Saluda Medical, Nalu Medical, Medtronic, and Spinal Simplicity. So thank you again for your continued support. Tim, we've discussed, this season about the exciting new therapies and what we can offer to our patients. Today, we want to change it up a little bit and talk about how we can stay compliant and protect ourselves from healthcare fraud and the powers that might be out there. So our guest today is a healthcare defense attorney who has secured multiple acquittals for pain management providers accused of healthcare fraud. I'd like to introduce Ronald Chapman, president of the Chapman Consulting Group. Thanks for joining us, Ron.
Thank you so much for having me. And I'll tell you what, you've got me sold on the meeting after hearing about everything you've got going on. I wish I could attend as well. It sounds exciting, but thank you for the opportunity to talk to some real healthcare professionals out on the front lines, treating patients and doing it the right way.
Yeah, thanks, Ron.
I was just going to say, Ron, welcome. It's great to have you here. And I think it's an important part. So, Patrick, thanks for bringing this topic to our members.
Absolutely. Yeah.
Great, Ron. Why don't you briefly talk about to us, just give us a little bit of your background and kind of how you got into this space.
Yeah, absolutely. I started in the United States Marine Corps. I became an attorney there, and I was a prosecutor for the Marine Corps. So one of the things that I did was do a lot of investigations in the United States and also in Afghanistan when I was there. And that's really where I kind of earned my chops in being able to look into a problem, figure out what the potential causes were, and try to correct it. So when I came out, my old man had a healthcare law firm for a long time. I thought about going to the Department of Justice, but I'd had enough time wearing that kind of prosecutor white hat. And I felt that I wanted to help real people and work for real people. So I started at the healthcare law firm and quickly built a practice defending specifically healthcare professionals. I went to get a master's in health law, which is over and on the top of my law degree, so that I could be more knowledgeable about fraud, waste, and abuse and compliance and these crazy regulations that we have to deal with. And since then, I'd say for probably about the last 12 years, I've been defending healthcare professionals. And for the most part, if a doc is accused of healthcare fraud or overprescribing, especially if you're an interventional pain management physician, you're probably going to end up my way at some point, especially if you're in the Midwest, but certainly throughout the country.
So Ron, why don't you just give us kind of a background of the current landscape right now with, government and the whole healthcare fraud situation?
Absolutely. And for pain management physicians, and this means, mostly the interventional side, this story is probably one that everybody knows well, but may not have it in context. So let's just start with 2016. We know the CDC guidelines came out. Those guidelines were not supposed to touch specialists. In fact, like the first sentence of it says, this is for primary care clinicians. The impact of that was that primary care doctors became concerned if they were prescribing over a certain morphine milligram equivalent. And they said, well, we're not going to do that because we don't want the CDC after us. We don't want our boards after us. And so they started either cutting patients off, or when they would send a patient to you, I'm sure you both had this happen, they would refuse to continue the primary care prescriptions while you were doing the injections, which means, like a lot of physicians, you'd have to have an in-office pain management visit with the patient even between the injections, which a lot of interventional physicians weren't prepared to do. Their offices weren't set up for that. You would do your injections and then, you'd send the patient back to the primary care for the next course. This started a host of problems because the CDC never communicated with the AMA or anybody to say, hey, do we have the ability to fill this pain management need with specialists if we're going to tell pain management physicians or primary care doctors that they can't prescribe? And so that's what created the problem. Well, immediately after that, pain management physicians, interventionalists rose to the challenge and started to see these pain patients because they were the specialists. Well, the federal government cruised the country and started accusing a large range of doctors of rapidly increasing the size of their practice and now coercing patients to receive injections by withholding their medication. We've seen this theory in many cases, including the Bothra case, which was a $450 million healthcare fraud acquittal we achieved in Detroit. So that's how this problem started, and we're really still trying to find ways to dig ourselves out of it.
So yeah, let's talk about some of the the federal cases involving these, and talk about specifically what you have done to help these pain physicians get acquitted.
And this is the reason why I started the compliance company. I for too long had seen doctors come to me after they were already indicted or after they'd already, fired their attorney and were really close to trial. And there's something we can do to help them out. Certainly, we can take on the case and help. But the place to start is in the compliance phase. It's before the Department of Justice sends you a target letter. It's before the DEA kicks in your door. And what we're able to do there is send actual healthcare compliance folks into your office to right the ship. If you're buying a practice, if you have questions about your own compliance, or if you have an employee that did something wrong, we can quickly get on top of that for a doctor. So we started the company really to help people move forward. But I still take cases where doctors call me because they've been indicted. Dr. Hansen is the most recent case that we've been able to achieve an acquittal. He was acquitted of every single count. He was a well-known interventional pain management physician. He'd hired many pain management physicians, interventionalists who'd been educated at the Cleveland Clinic or Mayo or other places. If docs out there think that this could never happen to them, I will tell you that I've seen physicians from all walks of life and all different types of education become a target of the federal government. He was afflicted with the same issue. Every doctor in that area of Kentucky, northern Kentucky, near Cincinnati, was pretty much shut down if they were prescribing opiates. Every pain management physician in that area largely had been indicted. There was nobody left. And he was the last. Well, there was a spinal surgeon, Dr. Durrani, who got into a lot of trouble. He fled the country, and then the feds still needed a target, so they put their sights on Dr. Hansen. After about a month of trial, and they accused him of killing 12 patients, we were able to get him acquitted. Sounds quite nasty that somebody might be accused of killing 12 patients, but I'll tell you how that works. Whenever there is a death where somebody has opiates in their system, most states are reporting that to the federal government or to the medical board. Coroners and medical examiners are making the assumption now that if somebody had a certain amount of opiates in their system, the opiates caused the death. Now, every toxicology manual will tell you not to do that, and then that's not appropriate, especially because of, as you know, and you're probably thinking, tolerance is an important factor to consider when we look at blood levels of opiates. Well, they don't listen to that, and they decide to move forward, accusing people who died of clearly a heart attack or some other issue being killed by the opiates a physician prescribed. It's unfortunate, but documentation, good compliance, and a reporting mechanism for those deaths will help a physician greatly.
So Ron, I have so many questions for you. I know we have a 30-minute podcast. I could talk to you for 5 hours because I've been involved in this in so many ways. So in West Virginia, we're part of Appalachia. We've been the bullying point of this whole issue. And so years ago, Dr. Kim and I would get patients referred to us on high-dose opioids. We would take them over and then do procedures to wean them off, right? Mm-hmm. So I've been involved as a consultant to our state legislature. We passed new laws that makes it harder for family doctors to put people on high-dose opioids. And that's really helped our overdose problem greatly. But I've also been an expert witness. And most recently, the famous case, McKesson Cardinal versus a county here in West Virginia. Chris Gilligan and I defended those distributors, and they won the case. But I've also worked for the federal government as an expert in pill mill cases.
Yeah.
Where people were killing people.
Yeah.
I mean, they were killing people. And a lot of those doctors settled out of court and went to jail for 3 or 4 years or home confinement. They should have been in jail for life, in my opinion.
Yeah.
So I know you're defending doctors who didn't do anything wrong, who were accused of doing wrong, but I've seen the other side. I've seen pill mills who don't really care about people's lives. How do you decide? So I have a daughter who's an attorney and one in law school, so I respect the legal field. How do you decide, when you get that case sent to you, is it a doctor like Dr. Hansen who did nothing wrong and trying to take good care of patients? Yeah. Or is it a doctor who really doesn't care if they kill 1,000 people to make $1 million? Yeah. How do you make that decision?
That is a great question. First, I've had a lot of cases in your neck of the woods in West Virginia. Dr. Krishan Agarwal, Dr. Roland Shalafu, both very good doctors. We were able to take care of them. They never were convicted of anything. Those were doctors on the good side. We certainly have some of our bad actors out there, and we need to be very careful to make sure that we're not pulling the wool over the public's eyes when it comes to defending sometimes the bad actors. I'll tell you that personally, I try not to make a judgment about whether or not a doctor intended to unlawfully distribute. I have to look at the evidence. And one of the things that I look for is this, and this is one thing our expert, Dr. Murphy, who we use a lot, will say, one thing we need to look for is there an intent to treat the patient? And is there use of a medication solely for the purpose of treating the patient? When we have those two elements present, perhaps a physician was maybe negligent. Maybe they didn't see the warning signs and wean somebody down. When we're talking about a criminal case, that is not enough for criminal liability. That might be enough for a civil issue and whatnot. So usually you can tell pretty quickly those doctors who aren't interested in treating patients, but would rather get them hooked for other purposes. I'll tell you that these days, the pill mills of 2007, 2010, the things that we used to see, robo-signing, oxycodone 30 milligram, no patient visit, it just doesn't really happen anymore. And I'm seeing more and more good doctors facing scrutiny where they probably shouldn't have.
Yes, I think you're absolutely correct. Let me ask you one more question here, but now back to Patrick for a question. So the other thing I get asked to look at sometimes is a doctor does, 50 stimulator trials in a month, or they do 100 epidurals in a month. Mm-hmm. And my whole group may do half that, and we're a pretty busy group. So then, the insurer goes to the government and says, this is a overutilizer without medical necessity. There were no, and so they asked me to review the charts and say, was there medical necessity of these procedures, for example, or was this fraud?
Yeah.
Just joined the wrong procedure. How we have a lot of members that are high volume because, there's so few of us out there who know advanced procedures that they get sent a lot of referrals who need help, and they do the right thing. And they do the proper procedure for the right reasons, but they're outliers on that bell-shaped curve. They're outliers. They do more than other people because they get sent very complicated cases who've already had medication, PT, injections, and now they're coming for something bigger. What would your advice to our members be about overutilization and staying out of trouble with that?
That is a fantastic question. And I can give you some specific advice on how to remain compliant with that. First, if you own a practice and you have multiple providers who are doing procedures, this is a situation that we had in the Bothra case. He had 6 other providers. What you want to do is make sure that you have somebody doing random audits to look at a certain number of charts with maybe an independent evaluator. It doesn't take too long to see if they're documenting the efficacy, if we're doing injections, of that injection. And we're looking specifically at the documentation and correct those. When the Department of Justice sees that you have a plan to spot check your people, your providers, oftentimes the mistakes will actually fall into the category of, okay, a difference of opinion. But where you don't have a compliance plan, where you haven't set that chart monitoring up, the DOJ is going to say, well, you don't get the benefit of the doubt because you didn't set a compliance plan in the first place. Now, for providers who are specifically doing procedures, not part of a large practice, or maybe they just want to engage in their own compliance and want to avoid overutilization, I'll say this, to a hammer, everything looks like a nail. A lot of people will say to an interventionalist, everything needs to be injected. I don't know that that's true, but one thing that we always need to be conscious of is communication with the other providers on the treatment team and ensure that you've got a primary care physician who's referring the patient for pain management so that you can engage in the course, and you've got that flow of communication with the treatment team. The other thing is, if your documentation of efficacy is cookie cutter and identical, every patient has the exact amount you need to meet the LCD, it starts to look a little bit strange. So what I like to do is recommend that providers actually have patients sign that note related to efficacy so that they're making the statement that this procedure has been effective. And that could be part of the informed consent for the next procedure. Hey, how was the last one? Would you like to get a next one? The other thing is be mindful of the local coverage determinations and the national coverage determinations. And when a patient is exceeding that, what you need to do is make sure that you beef up your documentation. There's nothing wrong with exceeding an LCD. Some people may disagree with me saying that, but truly there's nothing wrong with it. You just need a justification and you need to increase your documentation for it.
So I'm just going to add a comment to that and get Patrick the next question. So I often will say we did an additional level because based on the MRI, this was needed and my operative note. And I think that you make a great point. Patrick?
Yeah, thanks. You hit on some of the do's and don'ts on what to do and what not to do on being compliant. You mentioned, the burden of proof in terms of criminal and civil as well. Can you kind of touch on that? What's the difference between that and in terms of what should be documented as well?
Yeah, absolutely. And this is actually an issue in flux in the medical community. So let's take prescribing decisions. The standard for appropriate prescribing is normally going to be whatever your state board has laid out for your opiate criteria. You'll need to make sure that you follow that. Unfortunately, for federal prosecution, the standard for when a physician can be criminally charged isn't very clear. In fact, we have a case that's up in the Supreme Court right now. We're waiting for them to decide if they're going to take it, that is seeking to clarify exactly what that standard is, because it has confused legal scholars and physicians alike. When it comes to the civil standards, civil liability, we don't have too much in the way of civil liability for prescribing decisions where a physician has refused to prescribe. There are some cases, but those are relatively rare these days. What we do have, though, is a lot of civil liability brought on behalf of the government for healthcare fraud, false claims cases, for overutilization. And we also see the DEA filing civil suits against physicians for various reasons. I would say that a doctor doesn't need to worry too much about these different levels of scrutiny they may face, because if you have a good compliance team, you've got policies and procedures, you train your staff on them. And then the big ticket item is if you see anything wrong with utilization, with perhaps a bad procedure, something that went bad with a patient, you've got to investigate it, document it, and then incorporate those findings into your compliance plan. And I'll just give you a quick extra on that. In the Hansen case, there was a patient who had a bad outcome. He aspirated on the table while getting a procedure, and somebody documented in the chart that the patient smelled like alcohol. That was never investigated, and it became a huge issue in the case. The reality was he was not drinking. I was able to find that he didn't have any alcohol in his system when he was tested. But that documentation right there needs to be investigated and looked into, because it's very important.
Ron, we have a pretty diverse community and society here at Aspen, whether they're regions, states, countries.
Yeah.
Do these rules and regulations, do these differ from state to state, country to country, or is it pretty much a blanket statement?
Let's talk about the billing, coding, healthcare side of things, especially when we're dealing with Medicare and Medicaid. Of course, every doctor is aware that you've got different coverage determinations for Medicare. You've got different Medicaid policies. You almost need a separate group of professionals to be able to navigate all of these. So you're under shifting standards. I will say, for the most part, if you're following Medicare, usually you're going to be okay. Medicare tends to be the tail that wags the dog for everything else, so you're going to be good. When it comes to prescribing is both something that is controlled by the federal government through your registration, and it's also controlled by the state through some of their guidance in terms of what is considered the practice of medicine. So state guidance is going to be very important. I'll note something about that. When the CDC guidelines came out, a lot of states modified their opiate prescribing guidelines in order to reflect what was in the CDC guidelines. But the CDC later came out and said nobody should have done that, and I'm paraphrasing, because essentially these guidelines were just supposed to be helpful to doctors and not rigid criteria. Well, a lot of the states haven't changed. They still have that old information in there. And in fact, a doctor in Arkansas was recently convicted. I came on the case after he was convicted, but he was convicted for deviating from 2016 guidelines in 2024. It's insane.
So, Ron, let me ask you, I have a few more questions. I know we're getting near the end of the discussion, but I want to make sure we cover these. So one is, first of all, I'll make a comment. I think the 2016 guidelines saved a lot of lives, because I saw a lot of people dying because people weren't mixing benzodiazepines and opioids, very high dose. So I do think, while they have their faults, and I agree that they have some faults to them, in general, they're pretty helpful for longevity of life in a lot of people. Yeah. But here's the question: we have a lot of members who might get a letter from the federal government, from the local government, from some authority that says, Patrick, you've done something we don't like, right? Should they call their malpractice carrier? Should they call a local attorney? Should they call you? What should they do if they get a letter saying, we think you've done, overutilized a therapy, done too much prescribing, done too many procedures? What should they do first? Because I think that would be a stressful day in the life of that person, right? So they need some guidance, and we don't really know what to tell them. What would you recommend?
Yes, no, you're absolutely right. And I just want to mention, though, with the CDC guidelines, I think what we really need is the states and the federal government to get together and come forward with a common sense solution so that doctors aren't confused anymore. That would be the most helpful. But when it comes to notification, you might get a letter from an entity called Clarent that statistically analyzes your prescribing and then tells you if they think you've done too much. Or a pharmacy. We see pharmacy cutoffs from Walgreens, CVS, and others quite frequently. When you receive a letter like that, or even one from the Department of Justice, the first thing a lot of doctors ask me when they call me is, hey, does it look like I'm guilty if I get a lawyer? I hear that all the time. And my answer is absolutely not. When any entity gets communication from the federal government or any private entity like a pharmacy where there's a potential for litigation, the smart thing to do is get a lawyer, and not just any lawyer. Don't call up the guy who did your will. You have to get a healthcare lawyer who spends their whole day in these regulations because it's very difficult. In many cases, if somebody's been cut off by a pharmacy, our compliance group has a former DEA group supervisor who can do an audit of their controlled substances, draft a report, make some compliance recommendations, and we go back to the wholesaler, the pharmacy, and we say, hey, listen, we're doing exactly what you want us to do. And that's where everybody is aligned. Compliance, notification, making sure that patients are safe because we're doing it before there's a problem. That's really what they're looking for, and that's what we're able to help clients with.
That's a great tip, Ron. We have a lot of listeners from the industry side of things too. Everything from reps that come into the aura with us in our end cases, all the way to executive level executives. Kind of what is their role in this, and how can we partner with them to fight the healthcare fraud as well?
Well, I think that partner is the right word there. I think that we've got a lot of separate groups doing separate things that are putting different requirements on physicians, and that's where it becomes tough. There's a tale that I'm reminded of from the military. There was a book that we were required to read called Soldier's Load, and it was actually written by an Army general, but it was required reading for all Marines. And really it was talking about the bureaucracy that was putting equipment in the pack of soldiers because there were a lot of good ideas. Let's make sure they have an extra pair of socks or a shovel or whatever. Next thing you know, you've got people carrying a pack of 120 pounds around, right? And they're no longer effective in combat. And I feel like the practice of medicine right now is one where we've had a lot of good ideas thrown on the backs of doctors with the idea to save patients and help patients and physicians. But one thing that we really need to do is partner together to make sure that we're always focused on care of the patient, and that we're not engaging in policies or recommendations that are taking time and attention away from what's really needed, and that is getting people better. And that's, I think, a concern.
Ron, let me ask you one last question from me. I certainly have enjoyed everything you've said. I look forward to, hopefully we can have you down to Aspen next July. We have another attorney, Dave Daggett, who joins us. We have another attorney, Bill Tiano, who joins us sometimes. So you would be one of a trio. So good to have you there. Mm-hmm. But the question for me is, we talked about the physicians you defend who did nothing wrong, but were an outlier. Mm-hmm. But in every community, hopefully not every community, but in a lot of communities around the country, you have physicians that are members of our society. They follow the guidelines. They do everything they can. And then across town, there's some doctor doing really bad things. Yep. And the public can't tell the difference between that doctor and the doctor who's doing everything correctly. Is there any way we can police ourselves? That's my last question for you about our communities. We know what to do if we get in trouble to call you. And certainly based on our discussion today, I think you would be the person I would call. But what about when there's somebody else doing things that are bad for the community, bad for society? We see that. Is there any way we can police ourselves without getting ourselves entangled?
Yes, absolutely. I mean, I wish we lived in a society where you could, give that person a call and say, hey, is there something I can help out with? Maybe they're aging and need some help winding the practice up. We see that a lot. Maybe they're going through mental health issues. We also see that a lot. Unfortunately, that's hard to do. Everybody gets a bit defensive. Doctors in most states have a requirement that if you see a violation of your practice act, of your board rules, that you have to report it to the board. A lot of people don't do that. But you actually, and I hesitate to say this because I'm sure future clients are probably listening, but if you report a doctor who's engaged in some non-compliance to the board, you might actually be saving them an indictment. You might actually be saving them future harm so that their conduct doesn't spiral out of control. If the board looks at it and an investigator from the board comes in and they retain counsel and a compliance plan is developed, maybe probation is the result. Maybe a compliance plan is the result. And so I say, if we see something, say something. try to help, each other out. I think that's what we all have to do in this environment to keep patients safe. But great question.
Fantastic answer. Patrick, you want to ask the final question?
Yeah, I'll ask one last question. Just, we talked about what's going on right now, what happened before. What is kind of the future path towards this, and where do you see this all ending up?
Yes, absolutely. So the future path for enforcement, the things that docs should look out for, because honestly, you might be operating compliant today, but the rules change. And you need to make sure you change with the rules. So venture capital involvement is going to be heavily scrutinized by the Department of Justice. A lot of people are banging down my clients' doors with great investment ideas. If they are not healthcare professionals, beware and be very careful. Payment arrangements, always heavily scrutinized. I know that a lot have labs in their practice, and they've engaged in maybe some DME and other issues, but you need to beef up your compliance whenever you're adding those components to your practice, because you're going to be in a little bit more of a risk threshold. If you're taking on patients that have been discharged from other practices, you may want to have intake procedures that are significant and documenting information related to that. And then I would say injections are always very, very important, but telemedicine, everybody's aware there's a lot of flux in the telemedicine space. The DEA hasn't solidified whether or not you can still do telemedicine for a Schedule II after the initial patient visit. We should get regulations out relatively soon. And when that happens, a lot of things are going to change pretty quickly. We'll try to let our clients know and maybe jump back on and let you all know where the rubber meets the road there. But just make sure that you've got your ear to the ground of all the regulations, because you may be compliant today, but tomorrow can be a different story.
That's great advice, Ron. Why don't we wrap up, Tim, with your final thoughts?
Well, Patrick, I think we might put this on social media. This comment I'm gonna make right now. I think of all the podcasts we've had, the webinars we've had, but the podcast tonight, I think this may be one of the most important for many of our members to listen to Ron's knowledge of, really how to keep yourself out of trouble. If you're really a well-intended person who has good intent to help your patients, you need to have a compliance plan. You need to be compliant, and you may get out of compliance unintentionally, but you still would be in a world of trouble. So I think this may be the most important podcast we've ever done. And I think it may save lives, it may save practices, and it may save a lot of heartache if you get on board early and do the right thing. So I'm really appreciative, Ron, for you joining us. I think it was fantastic, and I really enjoyed your comments, and I look forward to talking more with you in the future.
Thank you. It was such a pleasure, and I really appreciate the opportunity. Thank you for having me.
Yeah, I totally agree, Tim, with all your comments, and thank you, Ron, for having us. They don't teach us this in fellowship or residency. We're always so busy, working, seeing patients with our families and stuff. So this is kind of a wake-up call to really focus in on how important documentation is and how important compliance is. So thank you, Ron. Ron, I'll give you the last word to plug your services and where they can find you if anyone's in trouble.
Yep, absolutely. So I think that you can definitely find me on my website, ccghealthcare.com. That's where you can find the compliance group. When I'm practicing law, chapmanlawgroup.com is where you can go if you've got a legal issue. And then certainly I think there'll be a click in the show notes where you can get link in bio and get the Twitter and everything else that you need if you want to keep in touch. And let me know if you have any questions. Just one other thing. Sean, the compliance guy, some of you all may know him out there, but him and I do a podcast together called The Wall. It's not in the area of healthcare, but we sit down and talk about a lot of pressing legal issues of today. So if you want something maybe a little bit more entertaining, that would be the place to go.
That's great, Ron. Thank you again for joining us. We hope to see you at our conference, like Tim said, in Aspen in Miami next year. And we'll make sure we include all your contact information in the podcast notes. That wraps up Season 2, Episode 7 of the Pain Unfiltered podcast. Thank you all for joining us.